Okay, I wonder if people could start coming inside and taking their seats, and we're going to be starting our a special symposium, which is thematically linked to our Gordon Murray lecture that we'll be enjoying after lunch. And as you know, has been described, the theme of kind of this year's Gallie Day is really focused on the future is now in robotics and surgical simulation. And we have a number of fantastic speakers lined up. So Derrick Tam is a cardiac surgeon scientist at Sunnybrook Health Sciences Center, and I'll just introduce all of the speakers just quickly. I won't read all of his background and his credentials, but he's been doing some very innovative work in the application of robotics to cardiac surgery, in particular mitral valve repair. And Dale Podolsky is a pediatric craniofacial and cleft surgeon at SickKids, and he's been doing some very cool work related to miniaturized robots and their potential role in facilitating craniofacial repairs in a less invasive fashion. Laura Donahoe is thoracic surgeon here at the University of Toronto, and her areas of interest include oncology and lung transplantation. She's also the program director for the thoracic surgery residency program, and Laura's area of focus is really in the simulation area and the application of this to teach skills in the thoracic surgery domain. And the fourth speaker in our mini symposium is Chaya Shwaartz, who is a general surgeon at UHN. Her areas of subspecialty focus include transplantation and HPB surgical oncology, and you know, she'll be speaking on you know, really kind of creating a whole surgical simulation ecosystem and sort of the applications of that. So and then that will be then followed by a panel discussion, and I'll kind of be monitoring the time. We may or may not have time after each presentation for some questions, but we have left lots of time for a panel discussion toward the end. Then I would ask after each speaker presents if they could just kindly take a seat up here. So first off is Dr. Derrick Tam, who will be speaking on simulation of robotic cardiac surgery, a paradigm shift in learning mitral repair.
Good morning. Before I begin, I want to say how meaningful this invitation is to me. I still remember my first Gallie Day as a PGY1, sitting in the audience in all the scientific presentations and the speakers, and wondering whether I would ever have the chance to contribute to this day from the podium. So to be here on my first year as a staff surgeon, giving one of the Gallie Day lectures is really a tremendous privilege. And it is fitting that the theme is the future is now, robotics and simulation, because today I want to highlight how robotic technology and simulation can really help our trainees become better learners and surgeons, especially when it comes to anatomy that is very difficult to see, such as in mitral valve disease. So I'm going to start with a story of my personal journey to robotic mitral repair. I went to Cedars-Sinai after finishing in the surgeon scientist training program here at U of T, having never touched a robot. And this is Dr. Alfredo Trento. He's one of the pioneers of robotic cardiac surgery. He taught himself how to do it at the age of 50. And he said this to me at the start of my fellowship. He said, "We have a year to teach you robotic surgery and mitral surgery, and you have to go back to start your own program. I don't know if we'll be able to do that." But why did he think that? Well, to better understand this, we have to delve into the anatomy and pathophysiology of the mitral valve. And I know that most people here are not planning to be mitral valve surgeons, but I hope that the application of simulation, practice, and robotics will be relevant to you, whether you're just starting in general surgery, thoracics, or any other specialty. And I'm sure that each of you have anatomy that might be challenging to reach or get to. So let's talk a bit about the problem at hand. Degenerative mitral regurgitation affects about 1 to 3% of the population. About 50% of people will require intervention over their lifetime. It is fundamentally a mechanical disease. If any part of the valve fails, such as the leaflet prolapses, a cord ruptures, or the annulus dilates, the valve will fail to coapt. And medical therapy may support the patient, and transcatheter edge-to-edge valve repair has transformed care for patients at high surgical risk. But for an operable patient with a repairable valve, the gold standard remains surgical repair. This matters because a durable repair can restore valve competence, and when performed at the right time can restore normal life expectancy. And this video on the left here shows a transesophageal echo of the mitral valve, a prolapse and flail leaflet with severe mitral regurgitation. You can see this color of jet going around the left atrium, and this blood is going backwards into the lungs. But this image was obtained by putting an ultrasound probe into the esophagus. This shows how posterior the mitral valve in the left atrium is. In contrast, this is the aortic valve. It's anterior and central. And this is the view that a teacher and a learner would get. And the teacher and learner have a shared view of this valve. But as I said, the mitral valve is posterior and deep. And in open mitral valve surgery, the best view is often occupied by one person. The teacher and the learner often have to take turns sharing the view, which makes it harder to develop a common understanding of lesions, segments of leaflets involved, and where each suture should go. So how does one learn to repair the mitral valve? The traditional paradigm looks a bit like this and is shown here. Open surgery is the foundation. Minimally invasive surgery often comes later, and robotics is treated as the final sort of advanced step. And there is truth to this. Open surgery is important. It teaches us judgment, exposure, tissue handling, bailout strategies, and the fundamentals of cardiac surgery and tissue handling. But the question I want to ask is whether this sequence is always the best educational pathway for learning mitral repair. And today I'm here to challenge that, and in some instances, robotic technology can help, with the aid of simulation, get our trainees to learn faster than traditional approaches. And this kind of shift is not unprecedented. In general surgery, laparoscopic cholecystectomy was once the advanced technique, and now many trainees learn to do this before they do an open procedure. In thoracic surgery, VATS, or video-assisted technology, has changed how trainees learn about hilar anatomy through a shared camera view. In urology, robotic prostatectomy has become the dominant platform in many centers. So I think the lesson here is that the educational sequence of an operation is not fixed. It may change depending on what technology advances and what the dominant platform might be. And I'm not saying that open surgery is obsolete. That's absolutely not true. The robot may not be appropriate in certain anatomic situations. For example, if patients have severely calcified blood vessels, we can't access the heart-lung machine. In sort of hostile chest anatomy, it makes it difficult for the robotic instruments to go in. Patients with severe annular calcium, it would be difficult to use the robot to repair the valve in these cases. Or in patients that have severe aortic valve insufficiency where the aortic valve doesn't close, it's just not possible to use the robot. So every robotic surgeon must be able to convert and manage any complications safely. And so the point here is that open surgery remains essential, but essential doesn't always mean that it needs to be the first thing that we can teach. So what are some of the benefits of robotic surgery? Many of these benefits are going to be highlighted in this video. I believe that robotics makes minimally invasive surgery much easier. With long-shafted instruments, the hand and wrist controls of the instruments are outside of the body. However, with the robot, the wrist controls are more intuitive, and they're at the level of where you want to be working, which is at the level of the valve. So with basic knowledge and principles of proper port placement and robotic docking, I think robotic allows more surgeons to offer minimally invasive techniques. And the 3D camera offers excellent visualization and magnification of anatomic details. And most importantly, it allows everyone in the room to have a surgeon's view. And we'll see a little bit of that through this video. This is us opening up the left atrium. and this is the team at the bedside, and they see exactly what I see. And the details and the magnification is just really superior. And everyone in the room gets this view. And here we're cutting out a flail posterior leaflet. Teaching robotic surgery is also a lot of fun. We have a dual console system at Sunnybrook, and this is true for most teaching centers. It's a bit analogous to teaching new drivers. And it allows us to safely teach robotic surgery by giving or taking control of all the instruments at any time. With a touch of a button. We can mark and draw on the screen for accurate description of suture placements, where to cut, and we can give real-time feedback given that we have a shared surgical view. So I believe that these aspects really help facilitate my own learning of robotics. And when I started fellowship, I had never touched a robot before, so I spent many hours on the computer simulator called SimNow, and it was a gamified way to learn all aspects of the robot, from how to move the camera to instrument exchanges. And you could practice all these basics tasks until it was perfected. And SimNow also not just tracks time, but also your efficiency in movement, how far instruments move. And this takes basic learning out of the operating room and into a safe and accessible location. And for residents on my service, they have access to this at Sunnybrook, and it's imperative for them to learn how to move the instruments before trying this on a live patient with the heart stopped. It's just simply not excusable to learn on real patients when this can be done in a safe setting outside the operating room. However, I believe that deliberate practice is also very important, and this can't be understated. So the SimNow alone is not enough to train someone to do this, because needles easily bend or break with a robot, and tissue handling relies on visual rather than haptic feedback. So having never used a robot before, placed too many mitral valve sutures, I devised a very basic model using robotic drape to form the left atrium and the mitral valve. And then the model was placed into an abdominal trainer. Industry provided some expired bands to use, and I spent many hours practicing on the robot before sewing on a live patient. So how realistic is this? So this video on the right shows an annuloplasty sequence. We did all our sort of annuloplasties in a very similar way. And on the other side is what it looks like in a live patient. This is actually a case I did when I was a fellow. You see the needle angles are actually quite similar. And you can practice the sequence as many times as you want outside of the operating room. And this video also highlights how well the mitral valve can be visualized with the robotic 3D camera, and how well the robotic instruments can also reach those difficult corners in very posterior structures. In real life, we use something called core knot to help fasten the sutures. When I was doing this and practicing, I did a human core knot, or I tied a knot. And this actually also allowed you to practice some other important skills, such as intracorporeal knot tying. So what does the future look like? I believe that robotics is complementary to open surgery, and that it does not replace solid open surgical skills. However, through parallel systems or streams, even junior residents can benefit from being in robotic cases. You don't have to be a senior resident or a fellow to benefit. One stream is simply just learning the anatomy, mechanisms of valve failure, how to plan a repair. By having a shared surgical view of the anatomy, I think this helps us do that. The second is correlating imaging, such as transesophageal echo, with intraoperative anatomy. A third is understanding how the robotic platform works, port placement, cannulation, bedside assistance. And then finally, there's the technical stream that can be learned outside the operating room, and with stepwise progression in the operating room to do atrial closure, suturing, and to do it via simulation, get feedback. And all this can lead to a competency-based type education in learning mitral valve surgery. I last want to show these videos. Simulation training is for all levels. At Sunnybrook, we held a robot week where we brought the robot in from Intuitive and held it at our sim center for an entire week. Each service got to use the robot for the entire day. Residents had 24/7 access to this robot to practice when the robot was not in use. In this first video here, we have medical students, residents, and fellows in all stages of training, practicing from port placements, using the SimNow simulator, and actually doing some knot tying on the actual robot. This second video is my mentor, Dr. Stephen Freems, giving his own try at using the simulator. His only comment to me was, it's not as easy as it looks. So the paradigm shift, I believe, is not that every mitral repair needs to be robotic. I think the paradigm shift is that robotic surgery and simulation are complementary and teach us mitral repair in a way that open surgery often may not be able to. The future is not robotics versus open surgery. The future is choosing the right platform to teach the concept of the right stage of training. At the end of my fellowship, I had a very different conversation with Dr. Trento. He asked me to stay in Cedars. I told him I couldn't. I had to go back to Toronto to build this program. And then he said, well, I believe you'll have no problems. Give me a call when you start. I'll be happy to come up and help you out. And in my 12 months of fellowship, we had transformed the way mitral valve surgery was taught at Cedars to fellows and residents and changed our beliefs on what graduated learning should look like. And I think the ultimate success of any fellowship program is not getting fellows to stay, but to get them to go back to where they're from, to their home, to start new programs. And with that, I'd like to thank the Gallie Day Committee for the opportunity to present this, and I look forward to any questions. Thank you.
So here's questions for the panel. Okay? Great talk. Very cool. So I think we'll hold questions probably for all the speakers actually on reflection for the panel, and then we'll be able to, I think, involve the audience and have quite a robust discussion. So the next presenter is Dr. Dale Podolsky, and he'll be speaking about miniaturized robotic instrumentation, design, and development.
All right. Thank you very much for giving me the opportunity to speak with you today, and thanks for the kind introduction. I do have the following disclosures. I am on the board of directors of a not-for-profit that develops, produces, disseminates surgical simulators for cleft surgery in low and middle-income countries. So I split my time between my surgical practice as well as co-directing a large engineering lab at the hospital for sick children called PSAGD. This is a surgical robotics lab, simulation lab, as well as a focus in medical device design. It's a very unique environment because it is an engineering lab within the hospital collaborating with surgeons in all disciplines. So I'm going to jump right in. So this talk is meant to be agnostic to the specific surgical robotic system, and I'm going to talk to you about the design of the instrumentation, which is really the heart of the system. So this, as we know, is the Da Vinci. On the left is the Da Vinci Xi, which is a multi-port system where each arm is separated from each other, versus the SP, which stands for single port on the right, where all the instruments are together. If we look at the Xi as an example, each arm, which used to be called a patient side manipulator, comprises of these joints. The joints of the larger arm are passively controlled to position a remote center of motion, which I'll talk about a little bit later. But this can, although it's passively controlled, we call them setup joints, it can actually be teleoperated or remote controlled by the surgeon. And within each of these larger arms is an instrument, and this used to be called an endo-wrist instrument by Intuitive, but these instruments are they have a common design across all systems, and they are designed like this for a reason. So they comprise of an actuation box or an actuation mechanism that is proximal, which controls a wrist or an end effector. And this movement is transmitted by cables. And the reason they are designed like this is because it allows for the miniaturization of the distal tip, which is really what allows us to do this minimally invasive surgery in tight corridors. It also deports the complexity proximally. So I want to focus on these wrists or end effectors. This particular wrist has a roll and pitch yaw grip function, and that's what allows it to articulate and interact with human tissue. These are typically between 5 to 8 millimeters in diameter, which is suitable for most adult applications. However, in my world, in pediatrics, it's too large. There are also other anatomical workspaces where this size is also not suitable. For example, for transoral surgery, maybe cardiac surgery. And I think there can be a lot of innovation towards further miniaturizing of these instruments to improve the dexterity, the reach, and the excursion of these instruments in tight corridors. So one of the pathways towards developing a novel surgical robot is to use a simulator as a test bed to understand the workspace for the design of these new systems. So my graduate work happened to focus on cleft palate surgery. This is a cleft palate simulator, but again, this talk is meant to be agnostic towards the specific procedure. This pathway can be used for any procedure. So I developed the cleft palate simulator shown here. This can also be used for surgical training, but I'm going to focus on the use of these simulators and focus on the design of these new tools. So this is just to give you an example of the fidelity of this simulator. This is an intraoperative view of a muscle dissection for cleft palate repair, and this video demonstrates the multi-layered structures of the simulator, the ability to perform all the critical steps of this operation from start to finish. Similar to performing this on a real patient, you can understand that this is an excellent test bed for developing and testing a new surgical tool, which might be a robot. So we flew down to Intuitive. This was in like 2015 to use the latest system. This was the XI at the time, and this uses those 8mm diameter instruments. And then, so this is that intraoral view. You can see the size of these instruments. It's just not suitable for an infant oral cavity workspace. So if we're going to design or develop an end effect or a wrist that is more suitable for tighter workspaces, we think this is going to improve the performance in these more confined workspaces where we currently can't or we struggle using the robot. And it might also benefit for working in existing workspaces such as large body cavity surgery in the abdomen. So what are the design requirements of an end effector with these capabilities? So we want it to have 3 degrees of freedom. So that's that pitch, yaw, roll capability. We want it to have grip function or grasp function. It has to be able to grasp tissue. Minimizing the number of components is really important because you're at the limits of manufacturability of the components at this scale. So you want to minimize the complexity in the number of parts. You want it to have really compact articulation. That's going to aid in the ability to operate in these tight corridors, as well as necessary force generation. I'm not going to go into detail, but the smaller the instrument becomes, the more difficult it is to generate the force required. So when we think of the classification of these end effectors, on the left is the classical, we call it a multi-link serial link manipulator. It's a pin-jointed design. The previous generation Da Vinci, if anyone remembers the SI, it had 5mm instruments. They had to redesign this to a multi-link design because they couldn't manufacture the components of the 8mm wrist at this scale. And then this is not an exhaustive list, but we also have continuum mechanisms. We do a lot of work in this area. These can be developed at sub 1 to 2mm in diameter, but there are other drawbacks to that design. So we tested the simulator with the 5mm instruments, and you can see that the size profile is much more suitable for this workspace. However, we actually found that the larger instruments performed better. And the reason for this is because it has a much more compact articulation. So this was really the motivation for my PhD work, was to develop a pin-jointed wrist at a smaller scale. You know, this was done by redesigning that wrist, but really to maintain the capabilities at a smaller scale. This was 3D printed in metal. This was in 2016. We have improved capabilities. Now you can see the surface roughness. It's just, you know, this is a starting point because we're at the limits of manufacturability at the scale. We proved that the workspace is much tighter with this new wrist compared to existing instruments. There's always a compromise whenever you gain something in engineering. The compromise for this was an increase in friction. We did a lot of testing to characterize that, and it was suitable. And then a master student continued this work, and she actually developed this instrument at 3mm in diameter. Again, looking at that typical instrument architecture, you have a proximal actuation system transmitted through cables to the wrist movement, and you can see the size profile of that 3mm wrist compared to the existing instruments at the time. And what's really exciting is since we embarked on this work, there's now a clinically available FDA-approved system called the Samani. This is meant purely for microsurgery, robotic anastomosis, and they have 3mm instruments, but these are not suitable for general surgical applications. So As a result of our work, we obtained a CIHR grant to further refine these 3mm instruments. We had a recent publication where we used these 3mm tools using our own Da Vinci research kit. This is an open source platform where we can build our own instruments, and you can see the improvement in the size profile of the 8 versus the 3mm instruments. This is a video. You know, this is a 20-year-old system, so the camera's not that great, but this is me attempting to perform a cleft palate repair. We did a lot of feasibility studies, and then we quantified the reachability within the oral cavity to determine, you know, where are the positions within the oral cavity where this system still struggles to perform dexterous tasks. And this really led us to something that I'm really excited about, and this is the next generation of this tool, which is the addition of an elbow joint on your right. And this is going to really significantly improve the dexterity and the capability of the system, and we also managed to do this at a very small scale. And you can see this is our physical prototype. That wrist is still 3mm in diameter, the elbow is 4mm in diameter, and this is the tool itself, same architecture, proximal actuation box, which transmits through cables movement of an elbow wrist. We're trying to move away from the Da Vinci, because the Da Vinci actually, it's an amazing system, but there are limitations to its overall architecture. And so we do a lot of work in addition to simulation in the physical realm, but in the virtual realm. Teng Li is a postdoc in the lab, computer science background, but we can actually build these systems in a virtual environment, test them, understand how to control them. And so he actually developed surgical tasks in a virtual environment using this system. This is using physical haptic interfaces. We've done a lot of work in that remote center of motion. The Da Vinci has a fixed remote center of motion, which really works well for body cavity surgery, but in transoral surgery, as an example, it can actually, you don't need a remote center of motion, and the position of that remote center of motion can actually impact performance. So we're developing a dynamic RCM strategy, and then here we have a peg transfer task in a virtual environment using both of these instruments. So this is a really streamlined view of developing these systems, and this is the physical system. This is our first generation tool, and now we're working on a second generation tool. And so I have 4 more slides. I'm almost done. You know, I mentioned that this is meant to be agnostic to the specific surgical procedure. I gave cleft palate as an example. We think this might be useful for pediatric surgery in general. There's a lot of interest in doing robotic-assisted pediatric surgery, but there just is no system that is suitable in size for this. But we're developing bone cutting technology. Joan Zaw is a PhD student who's been instrumental. We have a very large team, and using these same capabilities. You know, I'm not going to go into too much detail, but the use cases for craniosynostosis surgery to develop a snake robot to snake under the scalp to perform cranial bone cuts. And so here is our robot, which we're quite excited about, which again attaches to a 7 degree of freedom manipulator. It's that concept of how do you have multifunctionality at a distal end effector or tip at a very small scale. It's very challenging. So this has to have the ability to cut bone using a burr, an ultrasonic cutter, a bone punch, visualization, suction, irrigation at that tool tip, and the ability to be stiff enough to cut a bone. And so this is integrated with surgical navigation, preoperative path planning, where you just push the robot forward and it keeps you on path as the snakes around the skull, under the scalp. We have a digital twin on the right, which again, it's that virtual environment which allows us to test our control system for these robots. So we're quite excited about this as a new technology. So we're a large team, lots of people to thank, very, very smart individual, especially Thomas Louis, who is doing the day-to-day at PCGD. So thank you very much.
Amazing work. So the next speaker is Dr. Laura Donahoe, who will be talking to us about teaching senior learners technical skill simulation for thoracic surgery.
Great. Thank you so much. I'm really thrilled to be here to be able to present and discuss some of the things we've been working on thoracic surgery. I'm actually going to totally switch gears. We haven't yet done a robotic lung transplant. If you ask Marcelo, he really wants to get that on the books, but not quite yet. So we're going to go back to good old-fashioned open surgery because that's sort of where we're doing a lot of work in thoracic surgery. So just a little bit of background. I'm going to kind of tell you the story as to what we've been working on and where it started. So my first introduction to technical skills training outside of the operating room was as a general surgery resident. I actually trained at Dalhousie, but had a good experience there. And then when I came to Toronto, we had the interventional thoracic surgery course that we call the boot camp. And this was started by Gail Darling, and then Kazu Yazafuku joined early on. And we used to do it at the Mars building in the labs. And it's a course that's been going on for the last 10, 12, 14 years, something like that. And in the last 4 or 5 years, we have been absolutely fortunate enough to be able to do this at the Temerty Center. We've had such an incredible experience there, and it's really allowed us to take this in many different directions and really expand what we're doing and make this a really great course. We have residents who come from across the country in thoracic surgery. For those of you who may not know thoracic surgery, some refer to it as a fellowship, but it's actually a residency. So it's a 2-year Royal College residency program after 5 years of general surgery, so very senior learners. So, we try to focus on things at the boot camp to introduce trainees to different techniques. And, I think we could spend an entire hour probably talking about the merits or non-merits of things like boot camps. But, a lot of ideas have come out of the boot camp. And one of the things that we had always done was to use pig aortas and tracheas and do anastomoses. So in thoracic surgery, in general thoracic surgery, we rarely do anastomoses, but when we do, it's in complex oncology cases when we're doing sleeve pulmonary arterioplasties or sleeve bronchoplasties. And as a trainee, you might see a couple during your training. As a staff person, you might do one every couple of years. Like, they're pretty rare. So knowing how to do that and getting some experience practicing outside of the operating room is important. My other hat is that I'm a lung transplant surgeon, and all we do is anastomoses. So, bread and butter, we do the bronchus, we do the PA, we do the atrium. And so really important for our fellows to be able to have the ability to practice outside of the OR. So we had these holders that we made for holding the pig aortas and tracheas. And just before the pandemic, our engineers here at Toronto General helped us to make some fresh holders, which were sort of fortuitous because these things were clean. And the pandemic hit, and all of a sudden I had 6 surgical fellows from literally all over the world in transplant who had nothing to do because we closed our transplant program to all but the sickest patients. So I sort of pivoted and got these holders and made little kits to deliver to our trainees. I approached Scanlon, and they were kind enough to let us borrow instruments. And we started a virtual teaching program. You can see that at this point in time, the materials we were using were balloons because they didn't have access to what we were using at the time, which outside of the operating room was things like Penrose drains. So we used what we had, and the one in the middle is what I used because I didn't have enough holders, so I needed something to be able to show them how to do it. But the point of this, and we've gone from the most high fidelity in terms of technology with the robotic stuff to this what looks very, very low fidelity. But the point of this was to teach them how to sew and how to use the caster needle driver, how to do their needle angles. And one of our fellows actually published a paper on this, and these are his different attempts. And I know Stan's going to shudder when we talk about how doing any practice makes you better, which we know that. We know that any type of practice is going to make you better than no practice. But this is just showing what we were able to do after pivoting in the pandemic. And that's where this is all sort of started, and we have expanded since then. So I connected with a surgeon, Dr. Blair Marshall. She was at Harvard, and she's in Florida now. And I was very, very lucky to be introduced to Kate Kaslovich, who's a PhD candidate in engineering. She presented an e-poster earlier today. And we started to develop models for technical skills simulation in thoracic surgery. We had a bunch of different project aims early on and looking at, making these models, making things that are important and useful for our trainees, and then looking at ways of evaluating them. I did a master's in health sciences education after I finished my training. And one of the things that was really impactful to me is the fact that there seemed to be a paucity of technical skill simulation studies looking at senior learners. So a lot of the stuff I was reading was about junior learners and medical students, but not, PGY 6s and 7s and fellows looking at technical skill simulation. So I really wanted to develop something that was going to be useful to these, many times fully trained surgeons who were trying to learn these new skills. So this is what we started with. So we made these plexiglass boxes, and we wanted something to hold on to our vessels. We initially started again with Penrose drains, and then we developed this box model, and it's been an iterative process, and we've continued to make improvements. We started off with different size pegs, so we can increase the complexity of the task by sewing different size vessels to each other if you have a size mismatch. You can see there's a bronchus, and then we were still using the Penrose drains there, but different sizes. The red, yellow, and green things are Kate's design. She made, it's like a shot basically. So one of the other important things that came out of this is the fact that when these trainees are practicing, they don't often have help. So in the world of transplant surgery, similar, I think, to places, situations where you may not have the resources to set up, and plan for big labs all the time with lots of people around to teach and dedicate a lot of time to it. In transplant surgery, the issue we have is the unpredictability of it. So I could spend weeks booking a cadaver lab and spend, lots of money paying for these cadavers and set everything up. But if the morning of the lab, my fellows have 3 donors and 2 implants, there's nothing I can do about it. Transplant doesn't wait for anybody. So it can be really difficult to set up simulation for these trainees. So we wanted to come up with something that they can do on their own time. And I think this is applicable in the world of, we're finding limited time to do all kinds of things with our work hour restrictions and things like that. So having the ability for people to practice on their own is important to us. So these are some of the iterations of things we've worked on. We've done many, many different models. We started looking at silicones. Kate and I went to like a movie place where they sell different silicones and stuff to make I forget exactly what it was called, but called the store, but they have all kinds of different silicones that they use to make like masks and stuff for movies. So looking at different materials, that's a big thing for us because, my PGY 6s and 7s and fellows don't really want to be sewing Penrose drains. One of the important things that we're trying to teach them is how to be careful with handling the tissues and how much tension you can put on the suture as you're pulling it through so that you don't tear the fragile pulmonary artery or fragile bronchus. So, we looked at different types of silicones. We looked at different thicknesses. Sorry. Restart the video, but in the second one, one of our first iterations of the pulmonary artery is too thick, so then we made it thinner. That's a 3D printed bronchus, but it's not really the right material. It doesn't feel like a bronchus. So we've done lots of different things to look at really making these things realistic. This is where we started with the trachea. So this was back in the days of our engineers at Toronto General helping us. And the reason why we did this in the first place was because we were teaching PERC trachs at our boot camp, and we no longer had access to the model that we could do the PERC trachs on. So then our engineers made this trachea, and then we sort of built from there the idea of what we wanted. I developed this, 3D printed mold, and then that's our trachea or airway, a model that we've come up with. And what was really exciting is when we introduced it to the boot camp, our trainees actually liked it better than the PIG aortas and PIG pulmonary arteries, especially the ones who had experience in the operating room. They felt that it was more similar to what they were using. But we got good feedback, there was still more to be done. And, it's really important for them to be suturing on materials that are lifelike. And this is where we've come. So the video on the bottom right is an educational video that we made. Part of being able to learn on your own and practice at home is the fact that you might be practicing the wrong things. So you might not remember exactly what you were taught. So what we did was we created some educational videos so that the trainees can refer back to, the proper technique, and they can watch it on their own. And then the top left is the what it looks like in the operating room. So you can see that we really tried to make it fairly similar. I felt like I was on a cooking show when I was making this video, but our trainees tend to like it, so it's good. And this is sort of where we're at with our kit. Another really cool design part of this model is the pink thing, and you may sort of wonder what that is, but anybody who does any type of surgery where you're doing anastomosis, you know you need somebody to follow your suture. And so if we're making a kit where trainees practice on their own, they don't have somebody to follow their suture, this we don't have a name for it, but this suture follower, you can just sort of put your suture in it, and the little fronds are quite soft, but firm enough to hold the suture, but the suture will pull out as you go to your next stitch. So it's a way of making it so the trainees can practice on their own. Another thing we wanted to develop was a way for the trainees to test the anastomosis. So we look at what makes it, what makes it a success in terms of the anastomosis. So Kate developed a design for these pegs that you can actually inject, and this is always a highlight at the boot camp when we have our trainees do this. Everyone wants to see if their anastomosis will hold water. So it's a good way of sort of giving immediate feedback. And we've done, some educational intervention, a little studies. So this was 16 trainees. We looked at the effectiveness, and the way we formatted this was we did an in-person session. I showed them how to do it, and then we gave them feedback, let them practice, and then 2 raters rated their skills, and then we sent them home with the kits, and we had them do 10 practice sessions at home, and then we came back, as it won't be a surprise, they did better afterwards. So we're really exploring other research into the idea of practicing at home, practicing on your own, using video-based education, and then also doing video-based assessment. I'm sure all of us who are educators know that we don't have a lot of time to sit and watch and do all of the assessment of all of these things for trainees. So having other ways of giving them feedback and doing the assessment is really important. We're also looking at other things to simulate. So, in the thoracic surgery literature, at least, any type of simulation tends to be on cadaveric or pig heart-lung blocks. So, along the same line, all of those things are very expensive. And what we want to do is create other ways that we can teach other skills for other types of thoracic surgery. So a lot of what we do in thoracic surgery is dissection. And so getting into that proper plane on the pulmonary artery, dissecting out the vessels is really important. So, trying to teach that basic skill, we've created this, silicone adventitia, and trying to really replicate what it's like in the operating room. And what we're really excited about working on is coming up with segmentectomy models. So we'd like to be able to practice, segmentectomies, lung resections outside of the operating rooms. So that was a very early prototype of a lobe, but we're doing a lot of work on that. And an interesting thing that came off as an offshoot of this is we are working on the 3D printing for the lobectomy model, and different ways of making the vessels more lifelike. And silicone really tends to be the best material, but how to print it, how to make them hollow, and then Kate sort of inadvertently came up with this model, and I looked at it and thought, this is a pulmonary endarterectomy model. So, what we did was we worked with with the silicone on the inside of the 3D printed vessel, and then that is exactly what we do in pulmonary endarterectomies. So we put it in ballistic gel and set it up, and it's a really neat way of doing an endarterectomy. So lots of potential, and it's been really fun to look at all the different areas that we can explore in simulation. We've worked with Dr. Chaya Shwaartz, and I didn't say too much about this because she's going to come up next, but it's been a really exciting collaboration because a lot of the things that we had been working on in thoracic surgery are really applicable to HBB surgery. And, a pulmonary artery is the same as a portal vein, just maybe different size and different thickness, things like that. So, and then, obviously the ultimate is to look at skills transfer, because we want to show that practicing outside of the OR improves performance inside the OR. So thank you so much. It's really been a pleasure.
Yeah, very, very cool, very cool. And it's interesting, sometimes how crises like the COVID pandemic can stimulate innovation. It's a great example of that. So the fourth speaker is Dr. Chaya Shwaartz, who will be talking to us about building a simulation ecosystem at UHN from idea to impact.
Thank you so much. I'm too short. Thank you so much for having me. I'm very excited to be here, and Actually, I feel very honored to stand on this stage. My talk is a little bit different. I'm not talking about my research lab and what we do. I will mention what Laura and I are doing together, but just briefly. I'm more going to give you like the big picture of what we do at UHN. How are we creating an ecosystem? So this is a personal for me. When we have a patient that comes at 2:30 a.m. in the operating room for a transplant, they don't really ask us, did you guys prepare before? Did you do any training together? Did you practice any simulation together? No, they trust us. They really go in there and let us do what they think we know best. I think at this point, we always have to think, can we do better than that? Can we do something outside of the operating room to make ourselves better to get to that point? So my personal story is like, I'm originally from Israel. For many years, I worked in a simulation center. At the same time, I was in med school and then later as a resident. So Messer, the simulation center, is the biggest in the country. And there we spent hours and hours. Doing simulation was not an accessory or something that is just an adjunct. It was really, really embedded in our training. We spent hours and hours building simulation models from nothing. And I think that's what was really building my vision of how I see education. So this is a picture from an event that we do yearly. We started to do it 4 years ago. In June this year, it's going to be the 4th time we're doing it. We do 2 courses every June. And it's a workshop that we're doing for medical students. The way we started with this and came up with this idea was that I had a medical student that was rotating with me. She was like the best in her class in the preclinical years. But then she came to this rotation and suddenly she was not doing well. She got really bad feedback and she felt very, very frustrated. And I felt we have to do something about it. Then we started a conversation. It got me thinking a little bit. Then we started a conversation together with Emily Nguyen, one of my medical students that was at my lab there. She is now a resident in general surgery, an amazing resident. We started to talk about what can we do to make it better. And then we came up with that day that we are doing a full day, and it's not just hands-on. It's also other skills, how to communicate, how to present a patient, so how to be on a call when you're a medical student. So that was a really, really great day. But it was just a moment. And I was thinking to myself, is that enough? Is that enough what we're doing? Because workshops are just one moment, and it's not longitudinal. So it's kind of limited. What are we asking from our trainees? We're asking them to, a lot of times without previous training, to go into the operating room in a very, very stressful environment with very high stakes. And now they need to do very high-level skills performance under a lot of pressure. They can't really prepare for it. They can't do anything about it. Maybe they can. Maybe we can help them with simulation. So do we really think that workshops are nonsense, they're not helpful? What do we think about that? In my opinion, I know we talked about it from time to time, that workshops, it's just one moment, one day. But I think a workshop is an incubator, it's connectors, and it's catalysts. Why? I think it's connecting people together, it's a networking environment, it brings ideas, so it sparks a lot of ideas and things to think about. So I think workshops definitely has a very meaningful effect. So what if the learning did not stop here in a one moment? What if it's going to be something longitudinal from the medical students to the residents, to the fellows, to the staff? We can't just have one time and not invest in it in a longitudinal way. We have to take it forward. The simulation has to be effectful if it's happening in long term. That's why we call it the simulation ecosystem. So the way we see it, ecosystem and simulation, it's not one place or one event, right? It's something that you do more than that. It is an infrastructure. Infrastructure for a better education, infrastructure for better understanding, infrastructure for quality. And that's how we should look at it, and I think that's how we look at it at UHN, investing in that as an infrastructure. We have to talk about the elephant in the room. Every time we talk about simulation, we get into the discussion. What about the money? So simulation can be very expensive, okay? How high fidelity environments, advanced technology, protected time, we're all extremely busy, we're running around. Our time is money, so how is that possible? But in my opinion, we're actually looking at it very wrong if we think that's all about the money, because we're not trying to create any expensive simulation. We're trying to create a good learning opportunity that will be efficient and good for the learners. So it doesn't have to be very expensive, and I'm sure we're going to hear about it later today. So here's what we talk about fidelity, right? It's not how it looks, it's not how really what it is. We don't need it to be very expensive. We just need it to be very efficient. Fidelity is not how really it looks. Fidelity is that how it makes you feel, how well this prepares you. So I think it's something that is very important to remember when we talk about simulation. It doesn't have to be fancy, it doesn't have to be expensive. The most expensive simulators were the ones that didn't change anything after. It doesn't help us that we have a $50,000 simulator in a specific space if we're not doing anything with it or if it's not affecting what we're doing in the actual life. So one of the mistakes that we do, we always start from the tool instead of starting for the questions. What are we trying to do? What are we trying to teach? And this is why I love this, what Laura presented before. This is exactly that shows you that it doesn't have to be high fidelity. It can be something that is relative. It was a lot of work that put into it, but it's definitely not something too fancy. It was just amazing. Laura did an amazing work with Kate that I think I've even seen her here today, and if not, she's an amazing, amazing person that helps us a lot. With Laura's and Kate works before, we took that and transferred it to the transplant side, and we created this box to get the box into the learner. So this basically followed the learners to get home. They could take it home. My fellows, I see them standing there, took it home to practice on it and made them very, very excited and happy. And we also, all of these things were published. So this one was just accepted for publication that we both did. So I think this shows you exactly the point. It doesn't have to be a big thing, an expensive thing. It can be just good simulation tool that the learners can use. What about teamwork? So in the operating room, we're in a very, very, very stressful environment. You know, both of us are doing transplants. So we're in the operating room, bleeding. A lot of things are happening at the same time. But it's not only us. This is not an individual doing it. This is us, the learners with us, the residents, the medical students, the fellows. We have the nurses, we have the anesthesiologists. So what about the teamwork? So team simulation is also extremely important. We have communication, trust that we need to build. This is one example of an initiative that Jason and Alan were doing, and we taught, basically we did a simulation for us as an entire team. So surgeons, residents, fellows, nurses, anesthesiologists, and we did scenarios that were very stressful that can happen in the real life. So these things are very, very important and helpful for the trainees and for the entire team. This is a huge project, something that I'm investing a lot in with one of my students. We're working on the VR system. This is me looking at the case before the operating room with one of the fellows. This is before I live in Donahoe, but so it's a relatively, a right hepatectomy without a tumor inside. But we have a lot of these simulators or experiences in the virtual reality that we can show the tumors and when they are, and we sit. Because when we go into the operating room with our fellows, sometimes it's very difficult to tell them, this is you need to be careful from your side. They're standing on the right side, taking initiatives, but when you do that in a safe environment before, it's prepared them much better. So this is just an example of teamwork and how to prepare with the team. The same you can do with anesthesia in the virtual reality hub. This event is something that we're very proud of. Yeah, this was the first time we did it in last February, this couple of months ago in February. We decided we wanted, at UHN, with the support of Tom Forbes, we decided to do an event from all disciplines in surgery. So we took everyone, thoracic, ENT, neurosurgery, general surgery, etc., all the disciplines. We took learners, so it was a near-peer experience. All the stations had learners that were teaching, and the medical students were going between the stations. We called it from scalpel to specialty. What was amazing about this event is that it created a lot of excitement, but not just that. It created collaboration, networking, it created mentorship. So it built a community. And I think that's one of the most important things that happens during workshops and all these events. That's why I truly believe that it's important. I can't talk about simulation and not mention the telemetry center. I saw the team here. It's not a place, it's a concept. A lot of time we looking at it as a place that we just go there, do the simulation, but it's not. It's a place that we all sit together, we can talk about the ideas that we have. We have an amazing team there that we bring it from some kind of a small idea that we don't know how to take it to the finish line, and with the team in the telemetry center, we bring it to the end. We're doing really great stuff there, a lot of workshops there. So it's really a concept and part of that hub that I was talking about. So where it is going? So imagine a UHN when every learner has a pathway, every innovation has a tested. We all rehearsal together before any big case. We are ready to go. And the readiness is we did it by simulation. So we have a lot of things that we can do. We have Amin here to continue to invest in AI. We have a lot of other opportunities. We want to get global. We want to get outside of here. We don't want to just teach our people. In UHN, we believe that we want to teach also global surgery to teach other places in the world. And just from the time I'll get to this is a visit of us in Taiwan of the TVA Surge team, which I cannot mention. We're doing a lot of work on simulation also and innovation on TVA Surge. We went there to take the materials that we do here and invest in them and create something new there that will be similar to what we do here. So that day, taking you back to that day was very cool, but the goal was not to just do a workshop. It created so much more than that. It was the beginning of something else, beginning of this environment that we want to, the ecosystem that we want to create. And then for the patient that we talked about before, we should really not depend on luck. We should all practice before, go to the simulation, go to the telemetry, go as a team, practice together so we can get better care for our patients. And just to people that like simulation, this is an amazing book. And I just wanted to say, I didn't know that you'll be here, so it's very embarrassing. Actually, simulation is just another educational tool. And thank you very much. I'm very open to questions.
Well, we've had 4 excellent talks, and to round out our panel discussion, I wonder whether I could perhaps call on Professor Nataraja and Professor Hamstra to please join us on the stage. We might need to bring up an additional chair. Putting our visiting professor to work. Okay. Fantastic. So I wonder maybe if we could, and this we can open up, by the way, questions from the audience as well. But I wonder whether I might just kindly call upon Professor Nataraja and then Hamstra to perhaps just make some comments on anything you want related to these talks or anything related to this field. So maybe Ram first. Yep.
First thing to say is congratulations on 4 fantastic presentations covering the breadth of simulation practice. So I'm very impressed and awesome work, so keep it up. I think there's some important concepts that have come from that. One of them, which was touched upon, is the decreasing working hours, which we have universally for our trainees, and simulation can compensate for that. And what I was thinking certainly about some of the models that were proposed and have been invented and innovated by the speakers is actually we're incorporating actually competency assessments into it. So say for pediatric inguinal hernia repair for children, they have to do our low-cost model and prove competency before they progress. And I was thinking with the mitral valve, with their cardiothoracic simulators, those are things that actually we could build into a competency-based program. And I think the last presentation really does echo, and I think that for me, and certainly I'll probably give some examples of that, for me, low cost is high fidelity. So fidelity for me is how you use it and whether you're achieving your goals. And I think I'm speaking on the panel with a guru of this, so I probably shouldn't step too far out, but certainly with the functional task alignment can be low cost. So it's how we're using it, whether we're achieving our teaching goals and our learning objectives, not necessarily whether it's high fidelity in the older sense of the word, because I would actually say that's high technology, not high fidelity. It can be high fidelity, depending how you use it, but it might. But congratulations, amazing work happening here, and I congratulate all of the presenters.
Thank you. Stan, could I ask for your comments, please?
Sure. Thank you very much. You know, I started here in 96 or 97. I don't know. Ori, do you remember? It's a long time ago. But it's great to be up here and see so many friends and colleagues from way back then, and then all this new generation. And, you know, I started out with Richard Resnick and Glenn Regehr doing simulation research way back when. I kind of took a hiatus from the field around 2015 because I moved to the ACGME and I started looking at milestones data in the US and patient outcomes. So I wasn't really following the simulation field very much, but now that I see this panel, I really want to get back into it because this is super exciting. There are a few principles, though, that I think haven't changed, and one of them was this concept of, I mean, the use of simulation. You know, I love what you said at the end, Chaya, like it's like you mentioned that, I mean, you mentioned my book chapter, but you mentioned the point of it, which is simulation is really just another educational tool. So if you think about it that way, the whole point of doing it, and I think you all touched on it, is, you know, practicing in a safe environment, and then the question is, does it transfer to the clinical environment? So how do you measure the ability of those skills, that educational experience, to transfer to the clinical environment? So the transfer is the one big question that we need to address in this research. The other one, which is kind of parallel but a little bit different, is using simulation to assess skills. So that can be something very powerful because you can develop simulation to the extent that it equates with skills in the operating room. You can develop a very controlled situation for assessing how well people are doing, and you can make proxy decisions about, you know, where they need to focus on for the next stage of their training, or even whether they are ready to graduate. So that's all kind of the basic concepts really haven't changed in simulation in all that time. The one thing that I would like to kind of highlight is this concept of fidelity. It's a very complex construct, and people just make, when they first enter the field of simulation, they think high tech means fidelity, but that's not really a useful concept. The question, if you're thinking about the ability of the skills to transfer to the operating room, you want to know how do specific facets of the simulation design align with those skills that are necessary to interact with human tissue. So that's what I call functional task alignment as a replacement for the fidelity concept. So I just encourage everyone to think about that, about when you're designing your simulation system, does it align in a functional way with what you're going to be doing in the operating room? So, and then the final question I would have, I guess, for all the speakers is it possible? I mean, surgery is a very interesting specialty because we focus so much on technical skills, But we all know that surgery is much more than that, and I think some of you touched on that. It's decision-making, it's knowing whether to operate, it's knowing when to operate, how to do it. There's a lot of cognition involved in metacognition. There's communication skills, there's professionalism. So I'm just wondering how you would simulate those things. So that would be my challenge for the panelists.
Really, really great comments. And again, we can open this up also to the audience, but I might just start with a question for you, Derrick. And so that was really kind of impressive, and I could really see how, the robotics could prove, an advantage to access a difficult area and perhaps, with the articulation. So I guess a couple of questions. And I'm looking at one of the masters of mitral valve repair in the audience, but so do you think that, is this something that you're teaching your trainees, one, and two, do you think that this will evolve to become kind of the new standard of care? So, for example, the way arguably the Da Vinci has been for prostatic cancer surgery.
Thank you for those questions. To answer your first questions about trainees, I see it from, two perspectives. One, when I was at Cedars, the PGY3, PGY4s, they routinely worked on the console. And that's because at Cedars, they were exposed to robotics very early on in general surgery and thoracic. So they had those basic skills. When I came here and started doing robotics, I didn't expect to let my fellows do too much, to be honest. But then they started going on the simulator when it was free. When we had the robot week, they spent a lot of time on the actual robot. And they started practicing knot tying, suture placements, all that sort of stuff. And when you see them do it in a safe environment, in the operating room, it also translates. And I started letting them close the left atrium. That's where I started when I was a fellow, and they were able to do it. And if the stitch didn't look good, we both saw it, and we were like, nope, take that out. It was, and it felt very safe, and it didn't add too much time. With the robot, you can track exactly how long you spend with each instrument, how long the case takes on the robot. And our cases always take about 85 minutes to do, because we would allot a certain amount of time for the trainee to do it. And it can be done safely. And it's fun for them. And we've also allowed some of our staff surgeons to start doing parts of the cases as well. And it's also fun to teach some of your more senior colleagues who are helping you through the case to do it. It's extremely rewarding.
Yeah, it's really,
So I'm not sure if that, and then your question about, are we all, in the US, about 40% of cases, mitral repairs are done minimally invasively, 15% with a robot, 25% without a robot. Okay. In Toronto now, there's going to be 4 hospitals that will offer robotic mitral repair within this year. So we're expecting a lot of growth in this area, and we're working together to use simulation to train our teams.
You wonder, whether, the robotics might be the equalizer, if you will, in terms of, some of the talent aspects. Because this is, technically one of the challenging operative procedures in cardiac surgery. Requires a tremendous amount of skill, and as you're saying, there's all sorts of areas, and you wonder whether the robot, perhaps because of certain mechanical elements that it can do, might be a bit of an equalizer there.
It makes it much easier, because once you have basic knowledge of port placements, where the arms should go, with wrist manipulation, the movements are at the level of the valve. It's not outside the body with long shafted instruments.
I can really see that.
The needle angles are completely different.
Yeah, I can really see that. Fantastic.
Hi, everyone. Alan Okranik from UHN. Congratulations to all of the speakers. Incredible work that you're doing, and such amazing innovations and simulations. So it's just fantastic to learn from all of you. I wanted to get your opinions on the two of the main challenges, which many of you touched on, which is time and space. So Dr. Shwaartz mentioned, obviously there's the money and the resources needed for simulation, but time and space with the most amazing models are still two of the challenges that we have. And a lot of the work that has been done, this incredible work, has been after hours, the training at the end of the day, on the weekends. So what strategies are you using in your respective programs to create time for learners, whether it's the surgical residents, the faculty, or other members of the OR team? And then as another component of that is the space. How much of the simulation needs to be close to the operating room, in situ within the hospital, or what should be in the fancy simulation centers that we have across the city. We have VR simulators with the Da Vinci that are in the hallway of the operating room, and it's very, very close, but we may still not be realizing the full potential. So would love to hear your strategies around time and space. Thank you.
I wonder, maybe Chaya and Laura might ask you to maybe each individually kind of comment on that. Seems kind of perfect for your areas of expertise.
Thank you so much, Alan, for the question. It's a challenge, especially, and I know Laura will say the same, especially when both of us are transplant surgeons. The fellows are extremely, extremely busy, exhausted, invested. But that's why some of the things that we're creating, we are thinking also about that. Something that they can walk with it, go with it, do it in the middle of the day for half an hour. Even what you mentioned, that the simulator for the robot is outside of the operating room, if you look at the data that we have of how much time people spend on it, it's limited sometimes because they don't have the time. On the flip side of it, if they put it as a goal, they find the time, even when they call, suddenly they have nothing to do for an hour, they prioritize it, and we have to support them when they prioritize it. And the last comment I would say is that some of the big courses that we do, we have to do in a bigger space. So that's why we're using the telemetry center. For example, the Donahoe course, we started small, but even the smaller course for our fellows, that now is an international course, we can't do it in any other place. We need bodies, we need, so I think it's a really fine balance, and it's very difficult for trainees in these kind of professions that they really barely have time.
Thanks. I think it's important to have a mix as well. So yeah, I totally agree with everything Chaya said. I think that what we're doing with these models that trainees can use outside of the operating room doesn't really replace, though, coming together and, say, doing a cadaver lab and, what you can learn from that. We did one last year, and so much of the feedback was just that the value of getting to stand with your staff surgeon for 3 hours and getting direct teaching from them, like that was so valuable for our trainees. So, I think finding a balance between, but recognizing that, in an ideal world, we would spend half a day every single week at the skills center doing all of these things. Well, that's not going to happen. Can we plan that periodically, though? I think we should. It should be part of the curriculum. I touched on some of the barriers to that, and then we don't, it's the funding that comes with it. But I think it's on us to prioritize this and prioritize and say we have to make this part of the curriculum, part of our academic half days. Part of that should be simulation. I have maybe a bit of a controversial take, but I think that we're, in a new world, and I don't think we can continue to ask our trainees to do all of these things at nights and on weekends when they're not on call. It's a different world than many people in the room when you trained and when you even a lot of your practices. I think things have changed and are going to continue to change, and we have to just work with that and say, okay, well, let's build it in then. Let's build it in our curriculum. Some people say, well, you don't want to miss out on any time in the operating to do simulation, but if you're a PGY1 and you're going to be in the operating room as the second or third assist in, a big case where you can't even see in, is that truly as valuable as spending the afternoon, working on something in simulation? Like, I think we really have to look at some of our beliefs and sort of modernize things in a way. So I do think it has to be a balance, though.
Some really good comments. Stan, you have your hand up?
Sure. We were talking about this last night at dinner with Ram and Asha, and basically, if you could catalog a list of high acuity, low frequency procedures, things that the residents aren't getting exposed to that they really need to, catalog those, and then you can make a case for taking some time out of their day, because it's definitely a zero-sum game. If you take something out, if you put something in, you have to take something out. So it's a zero-sum game. But you need a rationale, and I think cataloging making the argument for what are these essential things that they're missing out on and then make the argument for taking time at half day or whatever.
Yeah,
I think
very
that would be
good
great.
point. I just have a question for Dale. I mean, the first time I saw you present this, I was just blown away. And I can remember doing, as a chief resident in neurosurgery, doing, a craniosynostosis cases with Jim Drake and Jim Rucka, and some of these are pretty big cases, right? And when I saw what you were doing, I thought, okay, this sounds cool. Now, are you actually applying this like in actual real cases, or is it still sort of in a simulation environment now?
Yeah, it's a good, can you hear this? Yeah, it's a good question. No, this is, at the current stage, it's at the academic level, I would say.
Yeah, okay.
We do have funding to do a live animal study, so that's the next step.
Okay, that would be amazing if you could actually kind of accomplish that, because that would, I think, quite dramatically enhance the safety and impact of these. Michael? Yep.
Jewett, I've been very interested in these presentations, and I wonder if the panel or some of the panel would like to comment on the before and after assessment of the impact of these simulators. And I was impressed by one of our visitors in Carol's rounds last January from Cedars, which incidentally the director is one of our surgical scientists from the past, Dan Teodorescu. But it was, I believe, Andrew Hung, you would know his name, and he was looking at tracking the robotic instrument tips and generating heat maps of gestures, which we intuitively always knew. And to me, it was a light bulb why somebody appeared to be a better surgeon than others, and you actually analytically could represent that. And these tools we're talking about, the before and after surely will help us to develop the best simulation.
Yeah. In fact, we talked about this at dinner last night as well, in terms of kind of using these tools to assess surgeon performance, either having somebody else assess you or you can assess yourself. I don't know if anyone wants to kind of comment on the application of these tools to do that.
I'll give it a go. So for the cleft palate simulator, as an example, we developed like the typical OSATS assessment method. It's incredibly time consuming to do it that way. It's very analytical, and I think artificial intelligence is for sure going to play a major role in automated assessments. I mean, the capabilities are astounding, but then you run into the issue you have to video record, right? So there's other issues, but I think that is going to make things much more efficient in terms of assessment for sure.
Yeah, and I think it's a great point, and I'll show a bit in my lecture, but we're actually using system-generated feedback. So it's not using AI, it's actually instrument tracking, and it's very much an objective marker of surgical performance. So you can give feedback, but then you actually have an objective. So rather than giving feedback, you need to use both hands equally, you actually have a marker. So it's at 80% on one hand, 20% on the other. So the technology is there for it, even for laparoscopic surgery and for robotic surgery, it's there as well. And I think we talked about time and money, and those are very important points, and faculty time is very, very precious. And this allows the self-directed learning of learners, and actually to really get the markers, improve, have objective system-generated feedback for their performance, and then once they reach a certain level, then have the faculty then view their performance and push them to the next level, and then the next level as a real sort of mastery learning program. So the technology does exist, and it's still not as defined as it can be, but a lot of teams are working on that. So it's a great point.
I think it really is a great point. Laura, there are some elements of your talk that really kind of resonated with me, and I really like the idea about kind of low-tech solutions to try to teach the basic skills. And sometimes I've been teaching courses for a lot of my career, and I found some of the surgical simulation systems that are available, they're impossibly expensive, and I'm not actually really sure that they do everything that they're saying that they do. And, you know, some of the skill sets, you know, are pretty basic. So I know like in spine surgery, one of the skills we teach are dural repairs. And so it involves the sutures and, you know, the three-dimensional handling. There's very expensive models, and then I've seen some really cheap ones, you know, that, and just your kind of your comments. So from a pragmatic perspective, like how do we kind of balance, you know, some of the things that we can kind of teach, you know, at a very simple level, and then, you know, obviously some of the stuff is very complicated, but what are your thoughts there?
Yeah, I feel sort of strongly about this, I guess, because of that exact thing. Like, you know, we have some very fancy simulators, but yet in the OR, you know, if the fellow can't use a Castro driver and doesn't know the needle angle, then a very fancy simulator isn't going to fix that. So I think it's important to look at, you know, and what Chaya was saying, like, what are we trying to teach? So, you know, I think in every specialty, you can sort of drill down to basic skills that are really important, and then looking at, you know, the most efficient and cost-efficient ways of teaching those skills. So we know some things you can only, like, you know, some things is really hard to recreate, and, you know, maybe a cadaver model truly is the best, and you can do that a few times a year, whatever it is. But I'm sure there's a lot of opportunity to look at these low-cost models to teach exactly the skills that you're trying to hone in on. So, and I think you're going to speak about that, you know, the low-cost models a bit later. So
Yeah, Dr. Hamstra?
Yeah, thanks. So let me throw a little bit of theory out there. So if we talk about validity of assessment, we can think about outcomes in the way that Dr. Jewett asked, and we can think about proximal and distal outcomes. So what are the proximal outcomes? The proximal outcomes in simulation-based training is, can you do this procedure well on the simulator? And then the distal outcomes are more like, can you do this in the OR? And actually, does it affect patient outcomes? So you can actually develop kind of a hierarchy of outcomes that you're looking at. So it doesn't have to be intimidating to collect outcomes data. You just have to kind of pinpoint the level at which you're collecting outcomes data. And then, you know, some of you may know Fadi Bala. He's the general surgeon from Ottawa. When I was up there, I think he's now a chair of surgery in Ottawa. But when I was up there, he was very interested in getting something that was really had great tissue properties. And I saw you were kind of, Laura were looking at silicon tissue and that kind of thing. But we developed this system we called guts in a box, where you kind of have a cooler and you have, you know, ports, and then you have like pig tissue or something in the box that really reacts in the same way haptically to human tissue. And so that is high fidelity in some sense, right? So it's all about trying to plan for, again, what I would call functional task alignment. Like, does it behave in a way that allows you to perform in the real setting? So yeah, kudos for exploring all those options and not being stuck with the high-tech stuff all the time. Just trying, and I noticed that each of the speakers had some kind of low-tech model to kind of test things out on, which is interesting.
Yeah, like I was quite impressed, Dale. I remember when you were, you know, surgeon scientist trainee presenting on that, you know, that cleft palate repair. I thought that was really cool, and you know, it seems like that, you know, was a really interesting way to go. And Derrick, like I liked, you know, what you had been developing, you know, trying to simulate. You know, the repair. I think those, it's kind of it's a bit of a balancing act, right? And not everything always has to cost $1 gazillion, right? And I'm not sure that those are always necessarily the best solutions. Having said that.
Yes, thanks very much, Chris Findell. Just one comment. I did have the privilege of teaching Carol Swallow through a thoracotomy when she was a fourth-year student on thoracic surgery, not on a simulator, but on a real patient. She did a fabulous job, by the way. But I want to comment. I just want to get some further comment. I can't remember who mentioned it. It was really looking at the time use. I think several of you mentioned in our training, and I think that's seems to be a real barrier to moving this forward. And what sort of things are we doing, perhaps along with the Royal College, to sort of make that big transition, to use this time better for our trainees? Because I think this is an excellent potential for training, but I think I see it getting sort of lost by the wayside because of the time pressures. Anyway, really enjoyed
Yeah,
it.
I think that's a great question. Who wants to tackle that one? Chaya.
I think we actually just got a grant for looking at, because we have to use the time also smartly, right? We can't, the residents, the fellows, they have like no time. At any given time, they have no time. But we are going to look at what happens if they only practice meaningful practice 10 minutes before they go into the operating room to do for example, vascular anastomosis. And if that's gonna, and then we're gonna assess if that's actually gonna help them improve in their technical abilities. Because I think once we'll know that maybe a short, because some of these short sessions, we still see that they have a lot of impact. So the time, we can use it more, efficiently.
Yeah, the other thing I was impressed in your talk, Laura, is that you were combining kind of the manual teaching with actually having a video to reinforce the learning. And I think that's very, very helpful. And you think about this, if, before a resident would go or a fellow would go do a surgery, so they've done all this, but to have a quick video just to go over all of this, the steps again, that's again something that is, practical and quite, quite time efficient, when you think about that.
Yeah, I think it's important, and I know Caroline Moulton was doing some work on this because a lot of the stuff that I say in that video is what I'm thinking about in that situation. Okay, well now my needle, now I'm pulling through here, but thinking about this, and I think watching surgical videos is good, but all the things on YouTube are the steps of the procedure. But I think also it's really important for trainees to know what we're thinking about as we're doing that step, because that's the important part. Yes, we all know we need to dissect the PA, but as I'm thinking, oh, that PA looks like it's bulging a little, maybe I'm concerned I'm going to go over here for that reason. Like, I think that's really important as well. To speak to Dr. Feindel's point, I think we have to incorporate it. So from a Royal College perspective, I sit on the specialty committee for thoracic surgery. So the boot camp is part of our suggested activities. And I think, I think Stan mentioned it before, like using simulation to do assessment. If we make EPAs that are simulation EPAs, then the programs are going to have to incorporate simulation and make it part of the curriculum. So I think there are definitely ways to do that.
Yeah, and I think also, an important component of all of this is also the research, right? The evaluation. So, often new ideas are associated with improved outcomes, but they're not always. And I think it's important to evaluate, because only through evaluation can you figure out what works and what doesn't work. So I think that's kind of an overarching comment that I might make for everybody, right? I think that's kind of intrinsic to what you're doing. I know a number of you are supported by grants to do the work, but I think that's that's critically important. It also helps to make the economic case as well, right? If you have the evidence to support that. So I think I'm going to draw this discussion to a close. I want to thank all of the speakers and panel discussants. Very, very, very good session. So we're going to take about a 50-minute break. We'll reconvene at 1 o'clock for the Gordon Murray lecture by Professor Nataraja, and lunch awaits you outside.